Good morning. Happy Thursday, everybody. Welcome to another VMR. On this awesome day, it's an all internal affair with the CP Solvers Academy, bringing you the scribing, the teaching points, the case presentation, and the code discussion. We're very, very excited for that. Since it is one of those rare days where it's literally a purely internal affair, I really wanted to take a moment to encourage anybody who's interested in joining this community to really keep up what you're doing now by joining us here live in VMR. But also, if you're thinking about it, presenting a case, we have a whole process that helps you put your case together, and it's very easy to find. If you found your way to VMR, you can find your way to the case presentation page. But just to share with simplicity, if you go to the main web page of the clinical problem solvers, and then you go to morning report. Here's the thing to read, and this is the tab to click on to help get some help presenting your case. I digress because our beloved Sohail is presenting a case, which is not a first. So this is case number 3. Is that right?
Yes, Robbie, you have a really good memory.
Oh no, I hang out. I spent a little bit of too much time on VMR, maybe. For other things, my memory is abysmal, but for VMR, my memory is pretty decent. We also have Salsan, who is scribing today, and Parisa, who's doing teaching points. But it is the very first for Elena to be co-discussing. I really emphasize this, and I say this a lot, but Elena really needs no introduction. Her name has become synonymous with VMR. I think she joined the academy almost a year ago, and I think was here every single day for like months on end. It became impossible not to bring her into the fold, and we're so excited. I feel like nothing better symbolizes Elena's dedication to VMR than what is happening today. So we're very excited for your first case discussion, Elena. And I know we talked about it offline, but just to get it out loud, how are you feeling right now?
Yeah, I've mentioned to the group before that I get to feel very nervous before for such situations, be it like job interviews or something like that. And I hope to like lose that a little bit going through the case. Yeah, I'm a medical student. I'm in my last year, and yeah, I'm super excited for this case. And I know that Soil always brings amazing cases. And I'm very much looking forward to discussing this case with you, Robbie.
Amazing. Well, hey, let's shed those nerves slowly but surely. And we can jump in, Sohail, whenever you're ready.
Great. So let's see, I have 6 aliquots, and the final aliquot will reveal the diagnosis. So starting with aliquot number 1, a 63-year-old male who presents with intermittent diarrhea for the past 1 month. And I can stop there or continue giving some history as well.
Whatever you had planned, my friend. What did you have planned before?
So let me just delve into some history. So
Okay.
symptoms began 1 month ago after returning from a 2-week trip to Mexico. 1 week after returning from the trip, he went to his PCP for evaluation of his diarrhea, but he was told that it was mild gastroenteritis and will most probably resolve. However, the diarrhea persisted. Patient has had diarrhea for up to 4 times a day, and this prompted him to the ED. The patient has not noticed any blood or mucus in the diarrhea. Prior to his travel, he has had a history of constipation, but no diarrhea, and no changes in diet that he could think of.
Awesome. Elena, I'm really curious, what thoughts are crossing your mind so far?
Yeah, I think so. In a patient with diarrhea, I think the first thing that I would like 2 things that I would make sure is maybe confirming that this indeed is diarrhea. Because a lot of times patients come to the ED and they complain of diarrhea, and I think it's very important to explore what they actually mean by that. If it's just a increase in frequency, but the stool is actually not is like has a normal consistency, so that would not be diarrhea. And then you can sometimes, and Sohail has actually just mentioned that the patient also suffered from some constipation. You can actually get like something that is called overflow diarrhea in the context of constipation. So that is kind of the first thing that I would do. Yeah, from a practical perspective, when you have like more than times a day, like a loose stool, and we would call that diarrhea. And then, yeah, I think the PCP was probably very practical about this, because a lot of times in diarrhea, we can like go into the direction of something that is non-acute if it doesn't go away. So I would have probably done the same, actually, to just like wait a little bit, make sure that the patient doesn't get too dehydrated. But it's definitely concerning that this has been going on for a few weeks and even like a month already. And yeah, we would go into a very, very different bucket, because if we have acute diarrhea, it is most of the time infectious in etiology, especially viral, sometimes medications. That's going to be important. But with this prolonged symptoms, we should definitely think of non-infectious causes, although infection can still be possible. Yeah.
Yeah, I think that's absolutely superb. You know, I think you, Elena, consciously or subconsciously, you exhibited a very important and often overlooked clinical reasoning principle, which is in acute presentations or hyperacute presentations, the mind deviates towards skewing for no misdiagnoses. So if somebody comes in very quickly with something, we will entertain rare conditions and rare presentations driven by their morbidity. And in the emergency room, we'll often say, what's no miss? What's no miss? What can we not miss in this patient? I think the equivalent condition or the equivalent principle for subacute presentations is to recognize that there are very few emergencies left, and that the only thing you want to get right from the beginning is not overlooking an emergency, but actually overlooking the true nature of the problem. And I think the longer a problem lasts, the more complex it becomes, and the easier it becomes to get distracted by things that are masquerading as something else. And you gave us a really powerful example of how the diarrhea may be masquerading as something else. In fact, it's exact opposite, with the patient presenting with constipation and overflow incontinence. And another practical example is the patient is presenting with hyperdefecation and not diarrhea. And so I think that really, whenever you're thinking about subacute disease, you're thinking mimics, 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 mimics. And one important category of mimics is the condition being mimicked. Is this actually diarrhea, or is this constipation? Is this actually diarrhea, or is this hyperdefecation? And then the other thing that gets missed a lot is the actual time course. Because when something's been going on for some time, you can imagine that the patient's confidence about something that happened 30 minutes ago is very different than their confidence about when symptoms started. And so here, it's very helpful to have a bookmark that this seems to have started for the patient after a trip to Mexico. But I think what would be really important to establish is, given the association of travel and diarrhea in people's minds, is this person exaggerating the connection between Mexico and diarrhea simply because of that knowledge? And importantly, does the diarrhea precede the trip to Mexico? And are there hints towards this being a much longer condition than the 1 month would suggest? So I think the mimics category, mimicking both the syndrome, which you did very well, and then keeping an idea for the time course being misleading, is really, really important. And I think you said it really well. If this is in fact subacute or chronic diarrhea, it's a very different landscape than acute diarrhea. And I know you were there for the Academy VMR that we did for chronic abdominal pain, and how chronic abdominal pain was all about trying to see what consequences the patient suffered to help you figure out what was going on. And if it was inconsequential abdominal pain, then the landscape was very different. And that same premise applies to diarrhea. What consequences has the patient suffered? Have they become markedly dehydrated? Have they lost a lot of weight? Have they been inflamed? Solving chronic isolated diarrhea is actually very, very tricky. Solving diarrhea with weight loss, or diarrhea with inflammation, or diarrhea that's keeping somebody up at night is much, much, much easier. So for me, I think I'm really, really honestly impressed by the mimics that you deployed. I'm extending the mimics to the time course, and I'm eagerly awaiting to see what accompanying features may make this problem easier to get to the bottom of, and prepared for the possibility that we're going to be stuck with just chronic isolated diarrhea, and that will be a challenge that faces many GI doctors to say, is this irritable bowel syndrome or something sneaking under that radar? But I wanted to pause there to see what questions you have about that, what thoughts you have about that, since I've babbled for a minute or so.
No, I think that's great. I love that you added the time course to our potential mimics, and I think it's a very important one. I didn't really pick up on the travel history, which could be a clue, but it also cannot. So yeah, I'm excited to explore that.
Awesome. All right, Sohail, tell us more.
Okay, so on review of symptoms, his general symptoms: no fever, night sweats, or chills. He has some weight loss. For the skin symptoms, no rashes or pruritus. No eye pain or redness. No changes in hearing. He did have a slight shortness of breath. No cough, wheezing, chest pain, or palpitations. For GI symptoms, slight decrease in appetite with mild weight loss. He went down from 204 to 189 pounds over 2 months. No nausea and vomiting. No epigastric pain or regurgitation. He had some watery diarrhea. No blood or mucus in the stools. For urinary symptoms, no difficulty in urinating. No pain or burning. And no notable neural symptoms. For the past medical history, he had one hospitalization in the past for bacterial cholangitis, which resolved after antibiotic therapy. And this was done in an outside hospital for which we don't have further records. Family history, history of colon cancer in father who was diagnosed at age 63. For social history, smoked 1/2 pack of cigarettes since 20 years, drinks occasionally every week, no drug use. For allergies, no known drug allergies. And for medications, ibuprofen as needed, has increased frequency of ibuprofen use in the past days due to right shoulder pain.
Sohail is such a great presenter. Thank you for keeping this so authentic and so real. Yeah, Elena, where did your mind start to go? What did you latch on to?
Yeah, so the very thorough, like questioning the patient because of the chronicity of the disease, I think, and that's really great. And I was actually looking for some inflammatory signs, like, for example, bloody diarrhea or weight loss. The patient doesn't seem to have any bloody diarrhea, but they do have weight loss. And if I got this right, then they lost about 10 kilograms in 2 months, which is definitely very concerning. And I think whenever somebody loses weight, the way I like to approach this is there something wrong with like taking in food to like go from all the way from the mouth to the anus? Is there something wrong with taking in food, like with dysphagia, that we don't have any signs in this context? And combining this with the diarrhea, I'm mostly concerned that there's a problem with reabsorption of the nutrients, which would actually, at least in some part, localizes to the upper GI tract, that could be involved. Yeah, I'm trying to catch up. I think there was some mentioning of ibuprofen, which is an NSAID, and that is definitely a medication that is associated with some enteropathies. I think NSAID use itself, I don't know how much the patient is taking, but the more you take, the more you're at risk for those kind of conditions. It is also associated with, I think, microscopic colitis, just to mention one differential diagnosis. I have also heard that the patient smokes and kind of drinks on a regular basis, if I got that right. And I think smoking can in itself cause some damage to the mucosa of the GI tract and can lead to diarrhea. But I think the patient has been smoking for quite a while, so I wouldn't expect this to happen to get like worse in the last month. With the drinking, like ethanol is like a sugar, and I think it can attract some water, so you can also get some diarrhea. So I would definitely try to talk to the patient if there has been any I don't know, increase in drinking, maybe some social problems, something like that. And then there's something else. So I was mentioned that that's colon cancer. There's some familial syndromes that are associated with colon cancer. But I think I don't go down this pathway really yet because it's very acute. So yeah, I think those are my initial thoughts.
Well, excellent connections between all the things. I really, really enjoyed how you latched onto the ibuprofen. I think that's a very powerful clue. The family history, the smoking, the alcohol, they're all really heavy things. But I love how you started with the weight loss, because I think now that this patient is a patient who's losing weight who happens to have diarrhea, and the diarrhea is a localizing clue to their weight loss. And so, as we talked about before, weight loss is the sinus tachycardia of subacute diseases. It tells you to pay very close attention. And if the patient didn't have any weight loss, then you might wonder, apart from the inconvenience, why is this diarrhea a problem? And so the weight loss here is very, very telling. And so in order to really make progress on understanding how the weight loss helps us in diarrhea, I think we have to go back to the first principles of chronic diarrhea. And in chronic diarrhea, we're taught to try to break down the cause of the chronic diarrhea into one of three categories. And you'll hear to try to break it down into inflammatory diseases, into osmotic diarrhea, and to secretory diarrhea. Let me just first explain why we don't do that with acute diarrhea and why that's only with chronic. Is because you don't need to do it with acute diarrhea. The differential diagnosis is so small, to try to figure it out mechanistically is just a waste of time, because the differential diagnosis for acute diarrhea is infection, medications, and maybe some other things. So chronic diarrhea is a much broader differential diagnosis, so it needs to be sorted in some way, shape, or form. So osmotic versus secretory versus inflammatory is actually not the simplest way to understand it, even though it's the right way to go about it. What we're trying to do, actually, is to say, is the origin of the diarrhea in the small bowel, in the large bowel, or both? Osmotic diarrhea means that there are osms that escape the small bowel, go into the large bowel, and trap water with it. They should not have escaped into the large bowel. They should have been absorbed and taken care of in the small bowel. So the small bowel is the problem. And if I look at the small bowel with an endoscopy, I will probably find the answer. That's osmotic diarrhea. The exception to that is when your patient takes an osm that the small bowel cannot handle under any circumstances, like a laxative. But most of the time, osmotic diarrhea, if not from an ingested unnatural osm, is from malabsorption. Secretory diarrhea is a colonic problem. The colon is supposed to reabsorb water, and if you poison the colon pathologically, it doesn't do so. And if I do a colonoscopy on a patient with secretory diarrhea, I will find the answer. So these two categories, osmotic or secretory, are ways in which the bowel can become dysfunctional without overt inflammation. Inflammatory diarrhea is meant to signify that there is now a macroscopically visible issue to the endoscopist. They can see that there is destruction of the GI tract, often with ulcers or even perforation. And those diseases tend not to restrict to the anatomy of the GI tract and can occur anywhere, generally speaking. So we have these three categories in front of us: osmotic, secretory, and inflammatory. And then if you were to prioritize which one of those conditions can cause weight loss, what would you think?
I think I'm very much inclined to thinking that this could be inflammatory in nature, the disease that the patient is presenting with, although of course, I mean, a malabsorptive issue could be at play as well, which could also be from the inflammation itself. But yeah, I think I wouldn't like completely rule out a only malabsorptive cause at this point.
Agreed. Yeah, I think what happens when you see what happens when a patient has weight loss with chronic diarrhea is it makes secretory diarrhea less likely. You can get weight loss with some forms of secretory diarrhea, especially those that are paraneoplastic in nature, but it usually is diarrhea plus chronic diarrhea plus weight loss, inflammatory, osmotic, secretory in that order, although all of them are still at play. So I think our future conversations will all be about how do we distinguish inflammatory from osmotic? And I think that's where we're going to go, and we'll talk about that then. I would just emphasize that in addition to understanding what is happening with the diarrhea, the accompanying clinical clues will be really, really cool and really important to study. So you already touched on all of them. Is the ibuprofen involved, and how does that spring into the mix? That helps us prioritize an inflammatory diarrhea called NSAID enteropathy. So I think the two themes that we're going to be studying in parallel, Elena, is what's the deal with the diarrhea? What is the diarrhea? And then what are the extra diarrheal clues that help us prioritize those mechanisms? And I think you latched onto all of them so far, and we'll see what Sohail has in store for us in the future. All right, we're ready for the next aliquot.
The next aliquot, on physical exam, the patient had a temperature of 36.9, blood pressure of 130/90, heart rate of 90, respiratory rate of 16, and O2 sat 97% on room air. General appearance, no acute distress. Pulmonary exam, clear to auscultation bilaterally. Cardiac exam, regular rate and rhythm. Normal S1 and S2, no murmurs, gallops, or rubs. For abdominal exam, soft, non-tender with no rebound or guarding, normal bowel sounds. Rectal exam, no tenderness, bleeding, or palpable masses. Skin exam, no rashes or lesions, and neuro exam, no focal or gross deficits. And I'll stop there. Physical exam.
Yeah, what do you think, Elena?
Yeah, I'm somewhat reassured by the vitals. So I was definitely concerned that this could be a patient that with all that weight loss could also be suffering from dehydration, but we don't see like a sign of tachycardia or hypovolemia. So that's reassuring. Something that I didn't mention before, because Sohail mentioned some like shortness of breath. I'm definitely going to be looking forward to seeing that hemoglobin in the future. Yeah, I'm glad that Sohail or the team did a rectal exam, because I think it's very important to look for blood even when the patient is not reporting blood. Something that also like we could also think of proctitis that doesn't usually cause rectal pain. That causes rectal pain, but not really diarrhea. But something that wasn't mentioned in the social history is definitely a risk factor for STI, especially receptive anal intercourse. But we're like reassured with the negative rectal exam. Yeah, I think from this point, the physical exam is definitely reassuring. Yeah, I think I'll stop there.
Oh, I completely agree with you. I think that it's amazing how this really conversation seems to be focused on diarrhea without any exam clues as to what the cause might be. There seems to be no extra intestinal fingerprints of this disease process. I think if we go back to the prioritization of inflammatory, osmotic, and secretory, I think secretory has been, or intrinsic colonic diseases have gone a little bit lower in my mind, because if somebody is having this much weight loss from a secretory process, they usually have dehydration. And we don't see, because remember, secretory is all about water loss. And so the exam is a good but not perfect test for marked volume loss. I wouldn't be shocked if his creatinine is 4 or 5, but there seems to be a marked disconnect between the amount of water this person is losing, the amount of weight that this person is losing versus the amount of water they've lost. And that water weight disconnect makes me even further lower secretory from from our CAC list. It's not off the table yet. You need a lot more data, but gosh, I think the inflammatory and osmotic categories are becoming even more prominent because of the absence of marked dehydration. All right, so tell us more, please.
So on basic labs, hemoglobin of 10.7, white count of 13K, platelets 530K, ESR is 27, CRP is 18, sodium 133, potassium 3.8, chloride 101, bicarb 26, BUN is 12, creatinine is 0.9, glucose is 95. For LFTs, for LFTs, AST is 46, ALT is 70, alphos is 323, T-Billy is 1.1, TSH, T3, T4 are all within normal limits.
Oh my gosh, so intriguing. What an interesting set of labs. Thank you. Elena, what do you think of that?
Maybe I can first summarize the labs because I think there might be some different values in in the German lab and here. If I see this correctly, we have an elevated white blood cell count. The hemoglobin is slightly low. There's some thrombocytosis. ESR and CRP are slightly elevated, and then I think the other lab is like chemistry is pretty much normal. Then like slight elevation in AST. We don't have the ALT yet, and the alphos is elevated, and the T-Billy is normal. Am I correct? Okay. Okay, great. Yeah, I mean, we didn't see any fever, we didn't see any tachycardia, but we do see that there is an elevated white blood cell count, so there must be some inflammation going on, which is also reassured by a hemoglobin of 10.7. I would definitely be curious in an MCV, which could point maybe towards an anemia of chronic disease or an iron deficient anemia. And I think for me, the platelets with the thrombocytosis is also just reassuring that there's an inflammatory process going on. Same for ESR and CRP. The ESR is like not sky high. Yeah. So yeah, I think it just reassures the discussion that we have that this is most likely an inflammatory diarrhea. Yeah, I think for the other values, I think the BUN is normal. Something that is interesting is sometimes the BUN rises before the creatinine rises when you have hypovolemia. So you could see an increase in the BUN to creatinine ratio. I'm also reassured that the bicarb is normal because in a patient with diarrhea, you could potentially expect a non-GAP metabolic acidosis, which is probably not the case here. And I think it's great that we have the TSH, that we have the T3 and T4, because hypothyroidism is definitely notorious for causing chronic diarrhea. Yeah, and I think the most interesting values are the alphos and the LFTs. So the LFTs are slightly elevated, and the alphos is definitely very elevated. I would, just to make sure that this is indeed a biliary process, get a GGT, but we don't really have any signs of that this is coming from the bone. So I would think that this is biliary in nature. We could have inflammatory processes in the biliary tree as well, but also obstructive. I think we can go very far with a point of care ultrasound here. Yeah, I think that's where I would start.
Amazing. You're really getting a lot of momentum to it. We're starting to understand this disease process better, right? And I think, as you said, this now is an inflammatory diarrheal syndrome with a high degree of evidence, with that CBC. And then we found an extraintestinal component, and that extraintestinal component appears to be hepatic in origin, but you want to confirm it's hepatic with a GGT because it could easily be bony alk phos as a result of low vitamin D from the diarrheal GI process. And so that's the one connection you want to make sure you don't overlook, because this could be osteopenia from low vitamin D. And so we're really solving this problem as a presumed inflammatory diarrhea with hepatic features. And I think it's really powerful just to see how with 1 hour in the emergency room or in the urgent care clinic or outpatient, wherever you got these labs, you can make that progress. And I think your analysis of it is absolutely superb. I'm curious, before I reflect, how do the nerves feel now compared to what you started?
Very. Oh, is that a question?
No, go sorry.
Well, after the physical exam, it was kind of like reassuring, but at this point, we actually did not know what was going on.
I'm glad we're on.
So we were overall reassured.
I'm glad we're on the same page, so I really am. Yeah, I'm not sure what's going on either, but I think we definitely have a couple of routes to make progress. How are the nerves feeling for you, Elena? How do they compare to the beginning?
Yeah, I'm starting to feel comfortable. I'm asking myself what I would get next, because at this point we don't really have an idea. Like, we have the idea that this could be an inflammatory process in nature. We have some signs of hepatic, intrahepatic involvement. Yeah, and I think confirming even more that this is an inflammatory diarrhea, I would definitely get that calprotectin in the stool. I think you can make some progress, although this is not really our discussion, whether this is whether there's some feature of osmotic or secretory with the osmotic gap in the stool. And then I think for the chronic diarrhea, we usually test for celiac disease. We test for giardia. And yeah, I think that's where I would start.
Yeah, that's absolutely superb. I think all those things are very valid. I think that, when you have chronic inflammatory diarrhea in the United States, the question is, this is inflammatory bowel disease until proven otherwise. But inflammatory bowel disease is an end diagnosis that's often accomplished by excluding 2 categories of important mimickers first. And the most important categories of mimickers are chronic infections that cause chronic inflammation. And a short list includes 1 virus, 1 bacteria, 1 fungus, and 1 parasite. A short list. The virus is HIV. The bacteria is TB. The fungus is histo, and the parasite is Entamoeba histolytica. Now, each of those categories have other considerations, especially CMV as a virus, especially a condition called intestinal spirochetosis in the bacterial category, paracoxy in the fungus, and strongyloides in the parasite. Many other ones too. But I think the most important test in this person is an HIV test. And then I think you need to go back to what you said earlier, which is, he said he was short of breath. Does he have a miliary pattern on his x-ray? And remember how he got fooled by Blasto and Shema's case that was presented, I think, 2 weeks ago, 3 weeks ago. So I think the shortness of breath you can't overlook, because it could easily be TB or histo. And histo is very prevalent in Mexico. So I think keeping track of that, as is Entamoeba histolytica. So I think a thorough analysis of these infections is really important. But the other arm of not getting misled by inflammatory bowel disease and closing too soon on that possibility is meds. And you said it. How much ibuprofen he's using is going to be really key, because NSAID enteropathy mimics IBD to a T, and histological analysis is often needed to distinguish the two, but more often than not, withdrawal of ibuprofen and resolution of symptoms is needed. I think the hepatic dimensions of this are really, really interesting. And I think it would be premature to try to make connections between that and that space and now. It would be productive to do so once we've said this alk phos is extrahepatic from biliary macroscopic biliary disease or intrahepatic. And you can then make inferences. So I think imaging will help us say what is going on with the alk phos, and then we can make progress. But if you're thinking chronic inflammatory bowel and diarrhea in the United States, your third pit stop is inflammatory bowel disease. The first and second are chronic infections and meds. And so we'll see where Sohail takes us on this journey.
So I'm going to give you some advanced labs right now. So for the iron panel, ferritin was high, transferrin was low, and serum iron was low. Vitamin B12 level was normal. Stools were positive for occult blood. For infectious workup, the stool culture, the bacterial culture, Shigella, Salmonella, Campylobacter, Yersinia, S-Tech was all negative. C. diff test was negative as well. For viral cultures, CMV, HSV was normal. HIV, Hep B, and Hep C was negative. For the room workup, some antibody tests. So IgA was normal, IgM was elevated, IgG was elevated, and IgG4 was normal. The ANA titer was 1 to 640. The anti-smooth, anti-cardiolipin, thyroperoxidase, ANCA, and rheumatoid factor were all negative.
What do you think?
Yeah, I don't know if I got everything, but for the iron fan, I think the ferritin was high. So I think this is just because of the inflammation and this being a acute phase reactant. And I think the transferrin saturation was low. So that would be iron deficient anemia. Yeah, it's reassuring that the B12 is normal, but with the diarrhea only going on for a month, I think we have storages that can last for quite some time. So even if there is like ileal involvement, we don't rule out that this is not the case with a normal B12. Yeah, I think I heard that CMV and HSV was normal, so I'm assuming that the IgG was like there, but no IgM, so no sign of like acute infection. Although I think CMV and HSV usually are confirmed by a biopsy, if that's the cause of an inflammatory diarrhea or inflammatory colitis. I'm a bit struck by the ANA because oftentimes ANA is just noise. You know, it's there, someone ordered it, we don't even know why. But with the titer of 1 to 640, it's really very high. And I think it's not just noise. It's something is there, some form of autoimmune disease. I don't know which ones of the IBD is associated with an ANA, but actually I would assume that they could all cause some elevation in the ANA. I think it's not very specific. Yeah, I don't know if at this point, like I don't know how we can proceed so we're not missing something with that ANA that we haven't thought of before, but maybe you can help me with that.
Yeah, no, I think there's really only 3 ANA positive diseases that are defining of the syndrome: lupus, scleroderma, and mixed connective tissue disease. Otherwise, the ANA really loses specificity for the disease process, and only in retrospect can you say, oh, that ANA makes sense. So what I do when I see this ANA result, which is definitely significant because of the titer and the gender, this person is a man, there's much lower rates of incidental ANAs in men. And so I think that this makes you emphasize autoimmunity, but it is not compatible at first glance with the 3 ANA defining diseases, lupus, scleroderma, and mixed connective tissue disease. So I just kind of put it aside and say, I know I worry that this person's autoimmunity is prominent, and the one autoimmune hypothesis that we have for his GI tract is IBD, and it might allow you to have some license to analyze his hepatic enzymes with autoimmunity in mind, hence the anti-smooth muscle testing that that Sohail got. And so you're like, hey, does he have an autoimmune hepatobiliary disease? But I think for me, I'm still in the situation where I'd love to understand his hepatobiliary disease. But so I imagine like imaging his hepatobiliary system and probably having to do a colonoscopy or endoscopy to understand the nature of his diarrhea. But I think I would interpret this, Anna, just like you. This pushes me closer towards an autoimmune disease. It, however, is not the clinical presentation is not synonymous with the 3 ANA positive diseases. So I'm just 1 inch closer to an autoimmune disease. But I think that if IBD hadn't crossed your mind before, it probably does now. And the hepatic analysis of, is this PBC, is this PSC, probably start to creep into our thinking. All right, Sohail, what you have next?
So this is aliquot number 5. This is the second to last aliquot, and the last aliquot will reveal the diagnosis. So for aliquot 5, we got some imaging. The right upper quadrant ultrasound, there was some thickening of the bile duct walls, no gallstones, gallbladder wall thickening, or pericholecystic fluid. For the ERCP, multiple strictures in the intra and extrahepatic bile ducts. Colonoscopy was done. It was normal. Biopsies are pending.
Thank you so much, Sohail. This is really, really illuminating. Yeah, what are you thinking, Elena?
Yeah, I think with the multiple strictures and the thickening of the bile ducts, this could definitely fit a picture of PSC. I have this like picture in my mind where you go from like big to small, and they look quite like that. Yeah, the PSC is definitely associated with IBD, especially ulcerative colitis. But I mean, the colonoscopy was normal, which definitely doesn't rule it out. But with the patient having active diarrhea, I would expect that you would have some signature if there is an IBD in the colon. Yeah, what else? I mean, sometimes I think I'm curious why the colonoscopy is normal, and if we find like a bug in the what is it called, in the histology, but something that could definitely look normal on colonoscopy is microscopic colitis. That's actually why it's called microscopic colitis, because you only see it on histology. So for me, this puts like microscopic colitis on one of the top of my differentials. And I think the microscopic colitis could definitely be explained by the NSAID use. And also, I think smoking is also a risk factor. I don't know how microscopic colitis is associated with the ANA. Yeah, I'm not sure about that. And one more thing that I wanted to mention, because I didn't really explore that before, and I want to make sure that I'm not missing anything, is the shoulder pain that the patient was that Sohail was talking about. I don't know if you saw like any signs of that this could be like inflammatory shoulder pain. Yeah, just curious what the exam was like.
Elena, I'll just jump in to say, like, it's so cool that you're tracking all these things. You track the shortness of breath, you're tracking the shoulder pain. I think it's the ability to track it is so important, because you don't want to be over obsessed with it, but to track it at the end is really, really cool and really telling. I am right there with you. I think that if you analyze the problem representation for the ALK-Phos is now changed to this being biliary strictures. And it's sometimes very obvious what the cause of the biliary strictures is from the context. Either the patient has a biliary stricture after a procedure in which injury of the bile duct is the culprit, And the other context in which it's often obvious is when the patient is critically ill and has ischemic injury to the biliary tree. So the two I's, injury and ischemia, are often readily apparent from the clinical context. Spontaneous biliary stricturing is often due to one of three categories. The most morbid is that it represents a cholangiocarcinoma. But it also can be a reflection of infections, with HIV cholangiopathy being an important one, and strictures as a result of chronic biliary flukes being another. Autoimmune disease, as you said, is usually PSC, but can also be related to IgG4 disease. So if you're making a quick schema for biliary strictures, it's like, is it obvious why ischemia or injury? Or do I have to explore because the clinical context is spontaneous? Cholangiocarcinoma, HIV, parasitic diseases, PSC, IgG4. So if we analyze the latter three categories, what happens is that the GI doctors do brushings to try to see if there are malignant cells that would suggest cholangiocarcinoma. In this patient, the intestinal component of the disease is the one that should prioritize PSC, right? And because PSC has a strong association with inflammatory bowel disease, which we've been talking about all hour long. But the question becomes, well, wait, are we just being completely misdirected by the bowel disease and by attributing the inflammation to be of gastrointestinal origin? Is the inflammation actually of hepatic origin, and the patient has a separate GI issue that is either of minimal significance or microscopic significance, i.e. microscopic colitis? So I think the question with the gastrointestinal component is, does it really prioritize PSC, or are we being fooled? And I think it has to do, our analysis has to be a function of the negative colonoscopy. If the colonoscopy were flagrantly consistent with Crohn's disease or UC, this conversation would be almost over. So the question is, how does the negative colonoscopy influence our analysis? And it's pretty rare, but in early IBD, the colonoscopy can be normal, and that's why it's a histological diagnosis ultimately. So our analysis of the colonoscopy is going to be, is it actually inherently normal? Or is it falsely normal because it's too early and the histology will answer the question and see findings? If it's normal, is it because the IBD is at play, but it's actually involving the upper GI tract and the small bowel? Or is it normal because this is not IBD and this is microscopic colitis? So I think there's so many possibilities about what the gastrointestinal disease process is. It's either IBD with subtle disease, or IBD that is in another part of the GI tract, or it's not IBD at all. But the bad news about diagnosing PSC is that it's a very tricky diagnosis that often requires exclusion of cancers and infections. But the progress we can make here is, of course, to rule out cholangiocarcinoma. But I think if you lock in IBD, you've locked in PSC. So what I would do in this circumstance is make sure we're not missing cholangio. But I think that the intestinal component of the disease process is really important to understand, because if you understand that, you can then understand the biliary strictures. Any thoughts or reflections on that?
Yeah, I think I'm a bit I'm definitely struck by the prominent signature of the biliary tree and the hepatic side, and yeah, I think it's difficult for me to see where the center of gravity is right now. But I love how you explain all of that.
I'm equally surprised that in a case with chronic diarrhea and inflammation, we have much more momentum on the hepatobiliary component than we have on the gastrointestinal component. I'm surprised by that, but it goes to show you how complex medicine can be. All right, Sohail, what do you have next?
So this is the final aliquot. So biopsies from the colonoscopy came back, and the biopsies from the rectum were normal. But there was some colitis in the terminal ileum with crypt abscesses, crypt atrophy, and no granulomas. The biopsies from the bile duct came back that they took during the ERCP. That was negative for any cholangiocarcinomas. And what was interesting was this antibody called the anti-Saccharomyces cerevisiae, which I was just reading about, that came back positive as well. So the patient was started on ursodeoxycholic acid, 10 milligrams per kilo daily, and budesonide, 9 milligrams per day. We also asked the patient to stop NSAID because we believe that the NSAID was probably making all this worse. And I'll stop there, and then I can maybe share some learning points later if you would like.
Elena, what are you thinking?
Yeah, I'm glad that the histology showed something, and we didn't have to look anywhere else. Yeah, it very much sounds like Crohn's disease to me, actually, with the involvement of the ileum, and I think the ASCA is a little, like, not too sensitive, but it's an okay marker for that disease. Usually I associate Crohn's with granulomas, but I think not everybody has those granulomas. Yeah, I think I'm reassured. I'm glad for the patient that they don't have a carcinoma. Yeah.
It's really it's a little bit of a shame for you both that you probably may not ever know what it was like to share this space many years ago, 4 or 5 years ago, and with people in your shoes, similar levels of training, discussing, because there was no VMR before that, and just the ability for two people who have not begun their residency training to present a case this way and articulate this case this way would have people's jaw dropping then, and they certainly do so now. I mean, I think, honestly, Elena, your ability to like sit here and casually think through all these hypotheses and articulate them with such clarity is unreal, and it's so exciting to see, and I really can't imagine what you'll be like when you've been certified for independent practice. It really is mind-boggling, and I think that the same is true for you, Sohail, with the very deliberate structure and how to make the story and help the story evolve. Yeah, I agree with you, Elena. I'm right there with you. I'm leaning towards Crohn's. The argument against Crohn's is that PSC has a much stronger association with ulcerative colitis. But I'm really curious what you learned, Sohail, and what wisdom you can impart on us.
Yeah, this case threw us in for a loop as well. So I guess I'll share like 4 or 5 teaching pearls really short. So when I did some reading, I think, like, first of all, we thought it was Crohn's because the biopsies from the rectum were normal and the terminal ileum showed disease, as well as the ASCA being positive, which is more strongly associated with Crohn's. There's nothing that's really diagnostic of Crohn's, and sometimes, the the IBD can be indeterminate. So a small percent of patients, we just don't know whether it's ulcerative colitis or Crohn's. PSC, more strongly associated with ulcerative colitis, but it can manifest before IBD. And surprisingly, sometimes, or most of the times, the severity is inversely proportional. So whenever PSC is more severe, the IBD is usually milder. And in fact, PSC and IBD together is clinically distinct, with the milder course, fewer clinical exacerbations of the IBD. As far as the ANA being positive, multiple autoantibodies can be elevated in PSC, including ANA. We didn't, we were in the same boat as you and Elena regarding that. Crohn's disease, clinical symptoms don't have to match what you see grossly on a visual inspection of the colon during colonoscopy. And I think those were the teaching pearls that I have.
So that was really cool. One of them was a lot of them are reinforcing and actually just tweaks of what I knew, but one of them was completely new, which is the relationship between PSC and IBD in terms of severity. Do you mind saying that one more time?
Yes, so PSC can
Yeah.
manifest before IBD, and that severity with IBD is inversely proportional.
Wow.
And several studies have suggested that the more severe the PSC, the
Hmm.
milder the course of IBD with fewer clinical exacerbations and lower need for biologic treatments.
Interesting. It kind of seeing that here, huh, Elena, right? Like maybe explains why the colonoscopy is so underwhelming. Like I didn't realize that PSC essentially like hijacks the severity of the IBD. That's really cool. Any reflections, Elena, on how it felt? Anything you learned? I'll pass the mic to you and then hand it off to our teaching points extraordinaire, Parisa.
Yeah, I think it was so much fun discussing this case, and I really loved your teaching points. Sohail joined the academy only a month ago, and I think it's like so cool that you're here. And I think yeah, whenever you present a case, it's so thorough and so yeah, just really great. And I learned a lot, and I know that you know a lot about this case, just the way you presented it, and yeah, that's really great.
Thank you, Elena. Amazing job. I know this was your first time, so great job. Almost like, almost I couldn't tell whether you were a resident until you were like, I'm a med student. So I was like, wow, really superb discussion.
All right, now for a trifecta of superb CP Solvers Academy members. Parisa, take it away.
Thank you so much, Sohail. It was amazing case. And Elena, oh my God, I cannot believe it. It was really great. All these amazing people here, really educational. We started with a patient who presented with diarrhea. We learned that in the acute and hyperacute setting, we need to rule out the misdiagnosis first, which could be infection and medication. In the subacute setting of the diarrhea, we need to rule out mimickers, which are hyperdefecation and overflow in the context of constipation. We learned that consequence of the diarrhea could usually guide us through the reasons behind. We need to pay attention to inflammation, dehydration, and weight loss of the patient. And then we reached to the weight loss. We learned that weight loss is like a sinus tachycardia of all the chronic diseases, and which is the order of the buckets would be inflammatory first, osmotic, and then secretory causes. We thought that secretory would be less probable because when we have weight loss in the setting of secretory diarrhea, the patient should present it with severe dehydration. We talk about different buckets of the chronic diarrhea, which is inflammatory, osmotic, and the secretory causes. It is helping us because we should help us to find the origin of the diarrhea. If it is coming from the small bowel, mainly it is osmotic. It in the context of malabsorption of laxative use. If it is coming from large bowel, it is usually secretory. The colon is not absorbing water. And when it is inflammatory, it will infect it in both sides. We talk about medication, and we talk about NSAID enteropathy, and when the patient is using the NSAID for a long time, we might have inflammatory diarrhea in this context, which is the mimicker of the IBD, and the clue for this diagnosis is when the patient stop using the NSAID, the symptoms should be resolved. We talk about chronic inflammatory diarrhea, which would be categorized in 3 buckets. The first is IBD. We could come to this diagnosis by excluding the important mimickers, which is in chronic infection. We have 4 things in this category. It's one virus, HIV, one bacteria, TB, one parasite, one fungus, histo, and one parasite, Entomoeba histolytica. We talk about diseases with ANA positive, which is lupus, scleroderma, and mixed connective tissue. Usually ANA positive, it's a noise, but when it is happening in a male patient, which raises our suspicious more toward inflammatory autoimmune diseases. We talk about autoimmune disease in this with ANA positive like PBC and PSC. This patient has biliary thickening and biliary stricture. We learned that the most common cause are the procedure in the background. And the other thing is that this could happen in the patient which are critically ill and the ischemia is happening with injury to biliary tree. But when we are finding that spontaneously, we need to think about cholangiocarcinoma, infection like HIV, and chronic biliary flux. If it is autoimmune condition in the context of biliary stricture, it could be PSC and IgG4. This patient has anti-Saccharomyces cerevisiae antibody, which is IgG-IgA, and it is associated with Crohn's disease. But we learned that multiple antibody could positive in IBD. Sohail taught us that Crohn's clinical finding might not match the colonoscopy finding, and it was really cool things that PSC and IBD severity could be inversely connected. The more severe PSC, the less severe could be IBD. It was really rich session. I was trying to capture some of those. Thank you so much.
Some of those, all of them, my friend. That was awesome. Thank you so much for recapping the whole journey from beginning to end. It was really, really well done. All right, well, I hope you have a wonderful rest of your day, and I hope to see some of you tomorrow. Bye.